Welcome to Talk to the Doctor About Insomnia, one of a series of audio cassettes on health and wellness issues co-produced by Durkin Hayes Publishing and the Heatherly Company. Talk to the Doctor About titles are exclusively available on paperback audio. This tape is designed to help you understand and resolve your sleeping problems. On Side 1, Dr. Frederic Flach, noted physician, author, and lecturer, will discuss the many types of insomnia and their causes. He will also dispel common misconceptions about sleeping and lack of sleep. Finally, he will briefly describe the many treatments available today to help you with your sleep problems. As you listen to this program, you'll be asked questions that may help you in correcting your inability to sleep. You'll want to review your answers later, so keep a paper and pencil handy to jot down your answers. On Side 2 of this tape, Dr. Flach will be talking with Dr. Charles F. Reynolds III. Dr. Reynolds is professor of psychiatry at the University of Pittsburgh School of Medicine and director of the Sleep and Chronobiology Center at the Western Psychiatric Institute and Clinic in Pittsburgh. Dr. Reynolds is a fellow of the American EEG Society and a member of the Association of Sleep Disorders, among other professional associations. He is the author of numerous scientific articles on the subject of sleep and sleep disturbances. Dr. Flach and Dr. Reynolds will talk in detail about how doctors can diagnose sleep disturbances and the approach to treatment that Dr. Reynolds recommends for many of the more commonly seen types of insomnia. Of course, this informational tape is not a replacement for proper medical advice and treatment. In all cases, we recommend you contact your physician directly regarding any medical conditions. Now here is Dr. Frederic Flach.
You're probably listening to this tape today because you're having trouble sleeping, or maybe somebody you know is suffering with insomnia. Be reassured, you're not alone. What can you do? Count sheep to get to sleep? Listen to the radio? Watch television? The Nielsen ratings indicate that some 20 million people watch TV at 3 o'clock in the morning. It's a safe guess that most of us at 3 a.m. would rather be asleep. Insomnia can take many forms and have many consequences. You can't get to sleep. You keep waking up all night long, or you wake up at 3 or 4 o'clock in the morning and can't get back to sleep. Maybe your problem sleeping has lasted only a few nights. You've been under some special stress, and hopefully, when you've dealt with it, your sleep pattern will go back to normal. Or maybe it's gone on longer. Maybe it's chronic, which means that whenever or however your insomnia began, it's been going on for weeks, months, even years. As a result of your insomnia, you find yourself feeling drowsy in the daytime, stressed out, confused, irritable. Perhaps you have trouble concentrating on your work or driving your car safely. Certainly these are serious matters, and that's why an entire category of medical research is devoted to the study and treatment of sleep disorders or insomnia. In order to understand what insomnia is, it's important to first clarify what sleep is. Sleep's a very complex psychological and physiological restorative process. Most medical studies indicate that a healthy adult averages 6 to 9 hours of sleep a night. 6 to 9 hours a night. This is what's considered normal and necessary for good health. The amount of sleep needed varies from one person to another, but it's been shown that every one of us has a sleep requirement that remains amazingly constant. And while occasionally over and undersleeping won't have a serious impact on your life in general, routinely getting more or less sleep than the amount your body requires results in physical and mental distress during the waking hours. Now, as I've already mentioned, sleep is a complicated matter. A lot goes on in our brains while we're asleep. Scientists and physicians have been able to measure brain activity during sleep using what's called an electroencephalogram, or, for short, EEG, which refers to a simple test in which electrodes are taped to places on your head. There's no pain or sensation involved. It's very much like having your heart tested with an electrocardiogram. These electrodes monitor brain waves and reproduce them on paper that flows through a machine so they can be viewed. EEGs depict very clearly what goes on during sleep. Our brains are constantly emitting electrical impulses. While we're awake, the most common type of brain waves are alpha waves. These are small and steady. But the pattern of brain waves changes substantially during sleep, and it's by examining these that doctors have been able to identify 4 important stages of sleep. Stage 1 is very light sleep, lasting just a few moments, when your body's making the transition from waking to sleep or sleep to waking. Stage 2 is also light sleep, when noises, sudden lights, or movements are likely to wake you up. But stages 3 and 4 refer to deep sleep, called delta sleep, after the big, slow brain waves that appear at this stage. During all 4 of these stages, the quality of our sleep fluctuates. REM, REM, or rapid eye movement sleep, occurs about every 90 minutes during the night. It lasts for 5 to 10 minutes, and while it's happening, an outside observer can clearly see our eyes moving rapidly from side to side. Now, it's only during REM sleep that we dream. You know, the final dream of the night often lasts for 30 minutes to an hour, and although we generally dream 4, 5, or 6 times a night, that last dream's the only one we remember, because often the dream occurred only moments or even seconds before we wake up. The rest of the night spent in non-REM sleep. Now, obviously, with all this activity, there's a lot that can go wrong, resulting in disruption of the normal sleep pattern. Insomnia. There are several different forms of insomnia and many different causes. The first differentiation is between people who have trouble falling asleep and people who have trouble staying asleep. The number of minutes it takes you to make the transition from stage 1 light sleep to continuous stage 2 sleep is called sleep onset latency. The amount of time spent asleep compared to the amount of time spent in bed is called sleep efficiency, something that's obviously compromised if you keep waking up during the night or wake up too early in the morning and are unable to fall asleep again. The first step in determining what might be causing your insomnia, thus knowing how to deal with it, is to evaluate the quality and quantity of your sleeping. Ask yourself these questions. How much do you sleep? How soundly do you sleep? Do you notice that it takes a long time to fall asleep? Do you awaken frequently? Do you seem to sleep long enough but never feel rested? When did your sleep difficulties begin? How long have they been going on? Look at your answers to the questions you've just asked yourself. If you have trouble falling asleep, and you've had it for a short while, your insomnia is probably transient, temporary. If you get it frequently, or you've had this problem for a long time, then it's chronic. And like many people, you've suffered from long nights and worse days as you've tried to function with too little sleep. Now it's time to look at the possible causes for your insomnia, and there are a number of them. Insomnia is generally considered to be associated with one or more of these categories of conditions. First, poor sleep hygiene, which means poor sleep habits. Secondly, lifestyle issues. Thirdly, psychological stress and distress. And fourthly, a variety of medical illnesses. Now let's take a look at sleep hygiene first, because poor sleep habits are not only extremely common, but they're one of the simplest forms of insomnia to correct. That's not to say it's easy. Changing habits that may have been years in the making can take some real discipline and effort, but it can be done. One of the things sleep hygiene refers to is the set of images that your mind creates about sleep, how you think about sleep. Does the idea of sleeping appeal to you, or do you perceive sleep as something you dislike to do? Have you made it a chore rather than a reward, or do you try to force yourself to go to sleep? Children, for instance, often complain about going to bed even though they need the sleep. And as we all know, this is frequently related to fears. Fear of the dark, fear of nightmares, fear of being separated from their parents, fear that they'll miss something while they're asleep. Generally, they grow out of it. But many people continue to carry negative images and unhealthy habits of sleep with them well into adulthood, which interfere with their own ability to sleep. What does sleep mean to you? What do you associate your bedroom with? Do you bring work to bed? Do you argue with your husband, wife, or lover in that room? Talk on the phone? Eat? If you do any of these things on a regular basis, it could be that your body doesn't know what you're getting into bed for. So remove the distractions from your bedroom, even your television set if it's a distraction, so that your mind can learn to recognize that your bed is for sleeping. If, by the way, you answered yes to the question about arguing with your partner, then you may both be living with a severe degree of tension that indicates the need for outside help or counseling. I've seen more than one patient who can't stand going to sleep on an unresolved disagreement or with hurt feelings, while his or her partner drops right off to sleep. People do have different sleep styles as well as different personal styles. Helping the upset insomniac partner to sleep better requires helping him or her to recognize that the other person may be actually seeking refuge in sleep and isn't necessarily any less hurt and upset by the arguing. I've encouraged such couples to try to understand each other better, and at the least try to avoid controversies late in the evening. Stress and distress in a relationship isn't to be taken lightly as a cause of insomnia, and it often won't be cured by the fairly simple measures that I'm going to be discussing next. But we'll talk more in detail about psychological distress and insomnia later on this tape. Right now, let's look at bad habits. Bad habits do make for bad sleep. Often we forget to make the place we sleep welcoming, although this is an important factor in a good night's sleep. Start with your bed. Do you have a good quality mattress? We spend a third of our lives sleeping, and an investment in a good mattress and box spring is one well worth making. If we sleep on a lumpy mattress or sagging box springs, we're ruining our chances of a good night's sleep, and probably our backs too. Now look at the sheets and coverings on your bed. Are they comfortable, clean, soft, and just as important, are they attractive? It may sound ridiculous to select sheets that are eye-pleasing to help you sleep, but remember you're trying to improve the image of sleep in your mind. I personally love a cozy, soft white comforter in the cold weather. Brown plaid sheets with rips and stains means I don't like my bed. I don't want to go to sleep. By taking the time to choose sheets, pillowcases, and other bedding that are appealing to you, you're making your bed more inviting and the thought of sleep more enticing. But don't stop there. The color and decor of your bedroom also has an impact. Loud patterns and bright colors have a stimulating effect on the brain and can contribute to wakefulness. Pastels are more restful. A gentle off-white or shades of green, lavender, pale blue, or pink are conducive to sleeping. This is something to think about if you have a child who seems to have a particular problem falling asleep. While the brightly patterned dinosaurs and action figures that populate today's wallpapers and borders may be fun and charming during the day, these very images may actually be quite distracting and even terrifying to a young child alone in the room at night. Try painting the room a more muted, monochrome shade, or selecting a wallpaper with clouds or flowers that will teach the child to associate sleep with pleasant things. And also adjust the level of darkness in your room to make it easier to sleep. Too much darkness often produces anxiety, but obviously a bright light shining in the room can also keep you awake needlessly. And it's definitely not a good idea to fall asleep with the TV on. If you're in the habit of falling asleep with the TV on, this is one habit you should break immediately. Although it may seem to help you to sleep, watching TV until you drift off may actually be increasing the amount of time it takes you to fall asleep and reducing the quality of the sleep that you do get. Many people do use television effectively to unwind at the end of the day, But it's better to select a program that will end at a reasonable hour so you can go on to bed, and watch something that's not disquieting, like fires and mayhem usually shown on the late-night news. Turn out the lights to watch, and relax on the couch. But when the program's over, turn the TV off and go into your bedroom to sleep. This technique may not bring about immediate results, but over time your body will learn to read these actions as signals for sleep. Now, once you've eliminated the environmental obstacles to good sleep, you can move on to tackle lifestyle issues that may be keeping you up at night. A regular sleep schedule is one of the best ways to get a good night's sleep, and one of the hardest things to maintain. Sleep researchers have done a great deal of work recently on something they call circadian rhythms, the approximately 24-hour internal clock that regulates a lot of our body's chemistry and tells us when to sleep and when to be awake. This clock is like a pendulum, moving back and forth, up and down, rhythmically. And when we vary our sleep routines, we can upset this delicate mechanism. Maybe you work too hard and too late. Parents with children often find they have no time left for themselves once kids are in bed and the household duties are done. How often do you push yourself to stay up long after you've grown tired, and then get up without feeling rested? If that's the case, then, after a while, your circadian rhythm is going to get out of sync and be unable to determine when you should feel tired. That's why it's important to get to bed each night at about the same time, give or take 20 minutes. And it's equally important to get up in the morning at more or less the same time. Sure, we're entitled to sleep a little longer on weekends and holidays. Scheduling is no less important for people who work evening or night shifts. Their sleep schedule just starts and ends at a different time. In this way, your body's clock will keep running smoothly and efficiently. There are several kinds of insomnia that are particularly associated with circadian rhythms, which recognize a cycle, as I said before, of about 24 hours a day, and send signals to your brain to tell you when it's time to sleep and wake up. And just as everyone's sleep needs vary, so do their circadian rhythms. It's interesting to note that young adults are often on a 25-hour day or longer, rather than a 24-hour one, meaning that they tend to stay up each night successively later simply because they're not tired. After several days, however, they may have a hard time getting up in the morning and will need to readjust their inner clocks to coincide with the rest of the world around them. This is usually not a serious matter and generally self-corrects by the early to mid-20s. In the elderly, the circadian rhythm clock grows shorter, which is why so many older persons develop insomnia. Their body's day is only about 20 hours long, so pretty soon they're falling asleep at 7 at night and waking up 6 or 7 hours later. Between the ages of 20 and 70, many things can happen to upset our circadian rhythms, such as long work hours, changes in jobs, changing from a single to a married lifestyle or vice versa, having children, social activities. You can probably think of several things this past week alone that kept you from getting to bed on time. When your circadian rhythms upset occasionally, it usually rebounds very easily. But if it's upset repeatedly, it can fail to reset properly and persistent insomnia can develop. Sunday night insomnia is very common among people who work weekdays, including students. While sleeping in on your days off may seem like a special treat, it can exacerbate insomnia as your body struggles the next day to get back on schedule. Hard though it may seem, try to get up no more than 30 to 45 minutes later than usual on your day off. And as for napping, well, the research in this area is not conclusive, but common sense would seem to say that if you're sleeping fine anyway, a nap can be a delicious respite. But if you're having trouble sleeping when you want to, then you should avoid napping in between. That way you'll be tired when you want to go to sleep. Circadian rhythms can also be thrown off by change of seasons. Some people grow excessively tired in the winter months because of the long hours of darkness. They sleep over long hours and continue to feel groggy during the day. There's a treatment called light therapy that might help, and your doctor can tell you more about this. Another place to look for a possible cause of insomnia is the list of your favorite indulgences. You know what they are. You already know they're bad for you, but did you know they're bad for sleeping, too? We're talking about cigarette smoking, alcohol, sweets, coffee, and tea. Each of these things have stimulant properties, and each should be avoided for several hours before the time you've established as your bedtime. Caffeine in particular can affect your system for up to 12 hours after you drink a cup of coffee or tea. A word here about alcohol. Most of us have heard that a small shot of alcohol or a glass of wine can help us sleep. This may be true sometimes, but there's a rebound effect when the alcohol wears off, and you'll often wake up later in the night. Moreover, the quality of sleep is often fragmented, and there's frequently a residual grogginess, a sort of mild hangover in the morning, and a danger of habituation. One drink can easily become 2 or 3. Alcohol is definitely not a solution for insomnia. So let's look at some more positive strategies for improving your sleep that don't involve drugs, like reading until you turn out the light, or listening to pleasant, calming music. For some people, white noise tapes are helpful. These play a form of static that helps to neutralize the many noises and thoughts that keep us up. Then there's the famous glass of milk, warm if you like, or a hot bath to soothe the muscles and relax the nerves. And here's one sleep aid that may come as a surprise to some of you: exercise. Exercise can be very relaxing. I'm not suggesting now that you do a full workout at 11 p.m. It is important to your overall health to do some aerobic calorie-burning exercises every day, but it's probably better to do these earlier in the day. The kind of exercise I'm talking about is calisthenic, muscle stretching exercise, like yoga, ballet, or just plain old stretching. A good stretch, 15 minutes to an hour before bed, helps to relax your muscles and prepare your body to sink down into the mattress with a pleasantly tired sigh. Whatever you choose to do, most experts agree that you shouldn't force yourself to sleep. Sleep is something we have to let happen, not make happen. Simply willing it won't make it so. You'll lie there growing more and more anxious about how tired you'll be in the morning, and your mind will churn with the things facing you the next day, and the sound of the clock humming or ticking on the nightstand will take on a nightmarish intensity. If you don't fall asleep within half an hour, get out of bed. Go back to the list of sleep cues and choose another relaxing activity. Now, so far on this tape, I've talked about some of the most common and easily managed forms of insomnia, those caused by habits or lifestyle issues that upset the circadian rhythms and poor sleep hygiene. But that's only part of the story. Insomnia, particularly in its chronic, persistent, or recurring forms, is often a symptom of a bigger problem. So if you've had sleep problems that have lasted for years and haven't responded to the kind of tactics that I've already described, it's time to look further for answers. There are some important questions that need to be asked, and a medical professional is the best qualified to interpret the answers. You may want to start with your internist or a primary care physician. Tell him or her what you know about your sleep problems, when they started, what was happening at the time, what patterns of insomnia that your insomnia takes, whether you have problems falling asleep or staying asleep. The clearer and more detailed picture of your insomnia that you can give your doctor by doing a little homework before your visit, the better able he or she will be to help you to determine the cause of your insomnia symptoms and to treat them effectively. If the cause is medical, that is, part of a physical illness, then your doctor will direct his efforts toward diagnosing and treating your condition, perhaps using sleeping medication on a very short-term basis. If medical causes are ruled out, Your doctor will then decide whether you should speak with a counselor or a psychiatrist about the stresses in your life and your emotional state, or whether you should be referred to a sleep center for further studies. But possible medical causes must be eliminated first. An enlarged prostate, diabetes, hypoglycemic episodes, these can disturb your sleep and can be managed with diet and medication. Reflux esophagitis, in which bile and other acids back up into your throat, and heartburn, a related condition, can often cause insomnia. Asthma and other respiratory illnesses that interfere with breathing can cause you to wake up frequently during the night. Almost any kind of pain, from a headache to a backache to a simple hangnail, can interfere with sleep until it's treated. And there's an unusual but troublesome condition called restless leg syndrome, in which patients can't sleep well because of twitches and movements and cramps in their legs. Or you might have sleep apnea, for example, a medical condition in which some people's hearts beat erratically during sleep and they sometimes stop breathing. The body defenses then wake them up so they can breathe again. It's usually not serious, and it is quite treatable. And of course, there are times when insomnia is part of a more serious medical illness, such as heart disease, thyroid disease, kidney problems, Parkinsonism, to mention a few, which is why it's so important to review your problem with your doctor to rule such conditions in or out. Medications can cause sleep difficulties. A number of cold medications contain caffeine and other stimulants that can interfere with sleep. But so do some drugs your doctor may have prescribed. Theophylline, used to treat asthma, quinidine, used to treat cardiac arrhythmias, thyroid hormones, steroid hormones, and even antidepressants. If you've gotten this far, made adjustments to your sleep habits, altered your lifestyle, eliminated the medical possibilities, and you still suffer from insomnia, then it's time to move on to other kinds of professional help. Your doctor can help you by referring you to a specialist who's most likely to deal with your kind of insomnia, such as that caused by stress and emotional distress. In this scenario, insomnia is a specific manifestation of internal tension and conflict, worry, fear, panic, anger, agitation, guilt, sexual problems. After all, why not? The bedroom and the bed do symbolize sex in most of our minds, and especially depression. Remember what we said at the beginning of this tape about the physiology of sleep. Well, the sleep electroencephalograms of people faced with serious stresses reveal a longer sleep onset latency, an increase in light sleep, a decrease in delta deep sleep, increased awakenings throughout the night, and nightmares during REM sleep. When we're upset about anything, most of us have a hard time sleeping, although there are a few people who have a remarkable ability to sleep through anything, and there are some who retreat from distress into sleep. Anxiety is probably the most prevalent sign of distress in human beings. It often translates itself into worry, and when we worry, our sleep is usually superficial and often interrupted during the night. The kinds of stresses that get to us most powerfully are those that cause us to feel helpless, out of control. The fact is that more often than not, if we examine our problems in a creative way, we will find solutions. Maybe not right away, but eventually. Accepting the fact that we can't control everything in our lives and having faith in ourselves, in a divine providence in our lives, goes a long way toward dispelling helplessness. Whenever insomnia is chronic, when we've been struggling with sleep problems for years, we should always ask ourselves whether we really could be suffering with a mild form of what we doctors call clinical depression. Now, we can't go into all the ramifications of what depression is and what we can do about it on this tape. It will be the subject of its own tape, but suffice it to say that every one of us gets depressed from time to time, and it's when we can't fully recover from the impact of depression that it becomes a clinical depression. And depression can be very clever. I mean, it can disguise itself in many forms. Tiredness, problems with concentration, loss of sexual desire, and frequently, very frequently, trouble sleeping. Most people suffering with chronic depression suffer with some form of insomnia, although, again, a few tend to withdraw into their bedrooms and sleep the day away instead. Now, there are simple and effective treatments for chronic depression, and if you're suffering with chronic sleep problems, you should ask your doctor whether you might be depressed, and if so, what can be done about it. If your insomnia is the result of other emotional pressures, especially if these are in response to a new event in your life, the death of someone you love, being fired from your job, going through a divorce, you and your doctor may decide to use sleeping medication on a very temporary basis only to help you get through the crisis. You'll probably start with an over-the-counter preparation. Most of these contain Benadryl, which you can buy generically much more cheaply. But the use of Benadryl is not without its problems, as you'll learn when I'll be speaking with Dr. Charles Reynolds on the other side of this tape. Since physical tension, muscle tension, is a common cause of insomnia, muscle relaxants can be effective to help patients get to sleep and stay asleep, particularly those with pain-related insomnia, in whom analgesics such as buffered aspirin or ibuprofen are often used as well. Your doctor, of course, can also prescribe a number of medications that are somewhat stronger and more specifically aimed at inducing sleep. Barbiturates have largely been abandoned because they're extremely habit-forming and can lead to drug dependency. Chloral hydrate may be used in special cases, as in hospitalized patients suffering with a variety of medical illnesses. However, today's standbys are the benzodiazepine sedative hypnotics, which can be very effective in restoring sleep. But in treating insomnia, they're to be prescribed for short-term use only, usually no longer than 2 weeks in most cases. To cut down on the risk of grogginess and fatigue the next day, or other unpleasant and sometimes impairing symptoms that can be caused by these drugs, doctors prefer to use short and intermediate-acting benzodiazepines, such as flurazepam, Dalmane, temazepam, Restoril, and triazolam, Halcyon. A new class of compounds for the treatment of insomnia has recently been developed. This class of drugs is structurally unrelated to the benzodiazepines, and these do not have the same effects. The first drug from this class is called zolpidem tartrate. It's available under the brand name Ambien. Unlike the benzodiazepines, this drug doesn't appear to suppress REM sleep, and people using it feel more rested when they wake up than with other medications. Currently, zolpidem has been approved by the FDA for short-term use in transient insomnia, while studies measuring the long-term side effects are underway. Remember, sleeping medications can be extremely habit-forming and can lead to a state of drug dependency. The benzodiazepines are also associated with a number of side effects, which include a reduction in your coordination skills, the skills you use to work a computer or drive your car, and what's called rebound insomnia, your sleep problems actually getting worse once the medication is stopped. In my own practice, I much prefer to prescribe small doses of the antidepressant trazodone, and when I say small, I mean small. Half or a quarter of a 50-milligram tablet. This works in a great many people, not everybody. Nothing works for everybody. But a lot of people who suffer from insomnia are helped with this, and in my opinion, it's a much safer, less complicated regimen to place any patient on. And perhaps, if your sleep problems are especially complex and resistant to ordinary treatment measures, your doctor may want to refer you to a sleep clinic. We'll learn more about what happens at a sleep clinic and how it can help you, and also about other approaches that you can employ to deal with insomnia on the other side of this tape, when I'll be speaking with Dr. Charles Reynolds, who is the director of a sleep disorder clinic and an expert in the field of insomnia.
Please turn the cassette over to continue this special audio program. And now we're privileged to join in on a dynamic telephone conversation between Dr. Flach and Dr. Charles Reynolds, a leading expert on insomnia and sleep disorders.
What should alert the physician or the potential patient to the idea of seeking help and assessment at a sleep center?
I think I can offer some fairly clear-cut guidance on that, Dr. Flach. If a patient is complaining of excessive daytime sleepiness, that's a pretty good sign that sleep lab referral may be helpful. For example, the patient who has trouble staying awake during meals or who falls asleep while in class or driving a car is someone who has potentially a life-threatening problem and should be seen, I think, in a sleep lab. The issue is perhaps a little trickier with the patient who has insomnia, but I would say if a patient has chronic insomnia that's not getting better with routine treatment, that becomes good grounds for sleep lab referral, or if the doctor or the patient has reason to suspect a disordering of breathing during sleep or some irregularity of heartbeat or abnormality of movements during sleep, then those also become reasons to consider sleep lab referral.
Actually, I have a patient now who is a young man, 50, who sleeps excessively during the daytime and then stays up till 2 and 3 in the morning. He's not working and has almost a kind of reversal in the sleep-waking cycle and is quite withdrawn. And I wondered if that isn't the kind of patient that you'd want to see.
That's an interesting situation, isn't it, in itself? Are you concerned that that patient might be depressed?
I've given him a variety of antidepressants and actually had psychopharmacology consults, and I can't tell whether or not he's shown some improvement, but I'm not sure it's not part of a major withdrawal syndrome that is on the basis of demoralization, but I've never encountered a persistent sleep problem like this one.
There's one other possibility, I think, that could be considered in that case, and that is the possibility of a circadian rhythm disturbance. You said your patient is 50, and that's a bit old for what I have in mind, but I think it could still occur. It's referred to as a delayed sleep phase syndrome. Basically, all that means is that the patient is unable to fall asleep until 3 or so in the morning and then tends to sleep until late morning or noon. Their sleep, physiologically speaking, is okay, but the circadian placement of that sleep is abnormal with respect to the 24-hour clock. Now, you and I have both seen examples of that occurring in the context of other psychiatric disorders such as depression or schizophrenia, but it can also occur in and of itself and not necessarily be associated with a mood disorder or a thought disorder. You think that that's a realistic possibility. That would also be, I think, reasonable grounds for seeking opinion from a sleep specialist.
Now, what happens when a patient comes to a sleep clinic?
Well, one of the things that we try to do very early on is to systematically focus on defining the patient's complaint and its history. On side one of the tape, you've very nicely laid out the multiple medical and behavioral and social factors that can produce sleep complaints, and we try to address that with patients and their families and at the same time to teach them about these factors. We do that in several ways. There is, of course, an initial interview that typically takes about an hour and a half with one of our sleep specialists, but that interview is preceded by some homework, if you will, on the part of the patient and their family. Prior to the first visit to the lab, we ask the patient to complete a 2-week sleep diary in which they record day by day when they go to bed, when they get up, how they slept, when they exercised, when they ate, whether they used alcohol, what medicines they took. In other words, we try to understand the patient's sleep complaint as it's embedded in the patient's lifestyle, which you've talked about very nicely on side one of the tape, that kind of prospective data is very useful for arriving at a preliminary diagnosis, but also, equally importantly, educating patients and their family members about how they may have to modify their own lifestyles to get a better night's sleep. The initial assessment by the sleep specialist also includes a review of the patient's past medical history and past psychiatric history, if that's appropriate. We like as well to interview either a bed partner or a family member who could comment on the presence of unusual behaviors during sleep. For example, loud snoring, difficulty breathing, or abnormal limb movements, which might increase the diagnostic suspicion of a physiological basis to the patient's complaint. Typically then, after about an hour and a half, and also based on a consideration of the diary that the patient has completed, we can usually come up with a pretty good idea of what might be going on, and then we can either recommend or not the conduct of formal sleep studies.
Would it be fair to say that everybody who tosses and turns and pulls the covers out and is restless may have a problem versus those who just go to bed, sleep, and hardly move?
The restless sleeper is certainly a common phenomenon, but the use of the term restless legs, as you know, applies more narrowly to a feeling of restlessness in the patient's legs, particularly near sleep onset, kind of an irresistible urge to get up and pace. Not unlike what we see in some patients who are prescribed antipsychotic medications, akathisia. In this case, though, sleep laboratory evaluation is very likely also to reveal the presence of abnormal limb movements, leg movements during sleep. We call that nocturnal myoclonus. And those episodes of limb movements during sleep are very likely to be associated with brief arousals during sleep. Patient may not even remember them, but the net effect on the felt or subjective quality of sleep is that the sleep is restless and non-restorative.
Well, how would you know as a patient whether or not to go get checked out if you're a restless sleeper?
Well, I think the key would be a sense of restlessness in the legs, particularly near sleep onset. A really strong urge to have to get up and pace because your legs just won't stay still when you're lying in bed and you're trying to fall asleep. That I think should be a tip-off that something might be amiss.
And that's a little different from waking up in the morning and finding out that your bed sheets are on the floor.
That's right. I mean, that could reflect certainly restless legs, or it could reflect something else.
Once you take the history, and by the way, in the history that you're taking in the patient's diary, what sort of things? Give me a couple of examples of what you might discover there that would clue you into a solution to the sleep problem.
Well, that's a very good question. I like to consider several things. First, I look at the basic rhythmicity of the patient's day. When do they get up? Do they nap? When do they sleep? When do they take meals or exercise? And one thing that I like to look for is either irregularity in the overall temporal patterning of activities. In other words, activities occur at very different times on a day-to-day sequence as opposed to a more stable temporal rhythm. I also like to look for the timing of different activities such as exercise, which, if it occurs late in the day, as you point out on side one, could have a stimulating or sleep-disrupting effect. We call patients so-called sleep hygiene abusers when their diaries indicate irregularity in the timing of sleep on a day-to-day basis. This becomes a real issue as folks get older. A good example of that might be the shift worker. But that's something that we can work with patients to fix, and which, if fixed, improves their overall chance of getting a good night's sleep more often than not. We also look at the amount of alcohol or self-medication that they report on the diary and when that tends to occur. We also look at what medications they report taking and when they report ingesting those medications, both of which could be contributory factors.
How might alcohol contribute to a sleep problem?
Good. Alcohol could contribute to a sleep problem, particularly if patients are using alcohol to treat insomnia or an underlying anxiety problem. Alcohol is great at rapidly inducing sleep, but the price you pay is pretty high. You get a rebound insomnia, particularly during the second half of the night as the alcohol is metabolized. I'd also like to point out, though, and this is very important in middle-aged and older men or women who snore, if you drink alcohol, someone who snores can become, frankly, apneic during sleep. That is to say, they can develop a complete occlusion of the upper airway, resulting in apneic episodes during sleep. So we really counsel people not to use alcohol for sleep problems. As you know, it not only will it worsen sleep, but it could also worsen or complicate any co-occurring emotional problems such as depression or anxiety that might be contributing to the sleep impairment.
What kind of medications do you find patients are taking, either over-the-counter or prescription? Just a few examples of medications that might be causing trouble with their sleep.
I guess a common example might be an antihistamine. People tend to use a variety of antihistamines, but these are not always helpful and sometimes can be positively counterproductive. Other folks may be using preparations for colds, upper respiratory tract infections, containing stimulants. Pseudoephedrine comes to mind as an example, which could be, I suppose, a sleep disruptor. But by far, I think the most important, from a public health as well as clinical perspective, is the use of either nicotine or caffeine, both of which are, as you know, stimulants. I try to quantify the amount of caffeine that a patient might be ingesting. It could average 100 or 200 milligrams per cup of coffee, for example. And I think people tend to get into trouble if they are ingesting much more than 500 or so milligrams of caffeine a day. Of course, that also depends on their sensitivity and what time of day they take it.
500 milligrams translating into how many cups?
Well, depending on the strength of the coffee, that could be 2, 3, 4, 5 cups of coffee.
You mentioned antihistamines. Now, Benadryl is used by a lot of people to help them get to sleep.
Not so good in my view. Let me tell you my concerns about that. Its effect on sleep is somewhat variable. Many folks also experience daytime hangover from Benadryl, which can be problematic, of course, depending on their occupation. And if you're dealing with an elderly patient, which I frequently do in my own practice, some of these patients can be susceptible to the side effects of Benadryl, particularly the anticholinergic effects, and making it a less than safe medication. The basic argument, Dr. Flach, that I like to make with my primary care colleagues is when you've got other medications that are so much more effective and safe than diphenhydramine, why not use them?
And we'll come back to those medications in a few minutes.
Okay.
It sounds as though everyone who comes to see you in consultation doesn't necessarily go through the whole process of laboratory monitoring of sleep.
That's exactly right. I would say that many patients, particularly with insomnia, really don't need the laboratory monitoring unless we suspect that they may have sleep-disordered breathing or a cardiac arrhythmia or nocturnal myoclonus, the periodic limb movements I was describing a moment ago. I think very often patients can be helped simply by taking a careful history and considering lifestyle issues and involving them in the collection of data prospectively about how they organize their days.
The circadian rhythm, which of course is that 24-hour cycle, give or take an hour in most of us, of a biological nature, which has to do with the waking and the sleeping cycles. Would you, if you had a patient like that, go ahead and do laboratory studies, or would you be likely to just approach it without them?
I think you're right in raising circadian rhythms and whether or not that's an indication for laboratory studies. A number of my colleagues would argue that that is a reason for laboratory studies, and what they would do in particular would be to monitor the patient's circadian temperature rhythm, the core body temperature rhythm, which is perhaps the most basic indicator of the brain's biological clock and its output. I think clinical practice, though, may be evolving into a somewhat more practical direction. And I think if on the basis of history or diary you have evidence of a phase shift, one can go ahead and employ certain techniques involving, for example, bright light or manipulations of the patient's sleep-wake schedule to try to realign that schedule into a more appropriate direction and set point. So I wouldn't necessarily go to the trouble of a laboratory study on the basis, say, of a history that suggested either a major delay or a major advancement in the circadian placement of the patient's sleep.
You mentioned bright light. Is that in any way similar to the bright light used in the treatment of the experience of getting depressed when it's dark and wintry and feeling better in sunlight, the thing we call seasonal affective disorder?
Yes, that's a good point about using bright light also to help patients with circadian rhythm disorders. I would cite in particular the work of my colleague Scott Campbell at Cornell, Westchester. Scott has shown that, for example, that bright light exposure in the evening can be very helpful to patients with advancement of the major sleep period. An example would be the older patient who goes to bed at 7 or 8 in the evening, but then awakens at 2 or 3 and has trouble getting back to sleep. Dr. Campbell's work has shown that bright light exposure in the evening can help realign the patient's sleep period to a more appropriate time and improve the overall quality of sleep. Now, that's similar in principle, in concept, to the use of bright light to treat winter depression. Bright light can help winter depression, as you know. It can also realign the patient's underlying circadian rhythms to a more appropriate phase position. That realignment may be part of the antidepressant effect of bright light therapy. That's an area of very active investigation.
Of course, if the problem was not that the patient went to sleep too early and woke up at 2 in the morning, but rather couldn't get to sleep until 4 in the morning, you'd be pushing that rhythm pattern in a different direction?
That's right. In that case, in the latter case, which perhaps is similar to the patient that you described to me before, some colleagues would prescribe bright light therapy in the morning, say around 6 or 7, to help phase advance that patient's rhythms back to a more appropriate circadian alignment. So what I'm saying in essence is that depending on the nature of the patient's circadian rhythm disturbance, the timing of light becomes important, whether you prescribe the timing of light in the evening or in the morning.
Now, of course, you and I know that this doesn't mean just going out and buying some extra power bulbs and turning them on and all your lights in your living room or your bedroom.
That's what it means, the use of special lights that have a particular intensity and a particular wavelength and quality. I think that this kind of thing should be conducted under the medical guidance of a specialist who is familiar with what qualities of light may have a therapeutic effect, and who also knows about whether the patient has ocular conditions that might make the use of light less than fully safe. So it needs to be medically supervised.
Ocular, you mean some kind of eye disease?
Yes, sir.
What sort of eye disease?
I think some people with macular degeneration, for example, might have difficulty with this kind of treatment. There are other examples. Frankly, I'm not up on that, and so I'll eschew any further comment on that point if I could, but I would make the point that this kind of treatment needs to be conducted with due cognizance of the patient's ocular status. It needs to be conducted and monitored by someone who's familiar with this area of treatment.
Now, at this point, we have a patient in whom you suspect a problem that lab monitoring would help.
Okay.
What does lab monitoring really consist of?
Basically, lab monitoring consists of monitoring the patient during their usual sleep hours. What do we monitor? Basically, we monitor the brain's electrical activity that constitute the stages of sleep, rapid eye movement and non-rapid eye movement sleep, which you've already described. However, for clinical purposes, we're particularly interested not only in sleep staging, but also in the patterns of the patient's breathing during sleep, heartbeat, and leg movement activity. What we're really looking for is whether there are physiological abnormalities in breathing, heartbeat, or limb movement that could be contributing to disrupted or fragmented sleep.
The hooking up to machinery and stuff is not particularly complicated for the patient or distressing?
I don't think so. We work hard at helping patients to feel comfortable. Most sleep labs, such as ours, have a series of very comfortable private bedrooms, the quality of a good motel or hotel. The sensors that are attached to the patient's body, usually an hour or two before bedtime, are lightweight and non-intrusive. I've had this kind of testing myself and did not find it intrusive, and most of my patients don't. The wires attached to the sensors are all bundled together in a nice, neat, small bundle, which are fed through a hole in the wall and connect up with the polygraphic equipment that amplifies the signal. The room is comfortable, it's temperature controlled, it's dark, there's a night light if the patient wants, and it's actually a pretty comfortable experience. The lab is quiet, and of course it is different from sleeping at home in one's own environment, and as such can introduce some new sources of error into the assessment of sleep. But I think that tends to be not a major problem for clinical purposes. A sleep study is similar in principle to an electrocardiogram in that it involves the attachments of sensors to the body for purposes of monitoring the underlying electrophysiological activity of a particular organ. But I would say myself, having also had EKGs, that sleep studies are even a lot more comfortable than EKGs because the electrodes, the sensors, are so much smaller than those typically used for an EKG.
What happens if I get in there, I'm the patient, and I lie down in the bed and you hook me up and then I just can't get to sleep?
That's okay. If you want to get out of bed, you can easily unhook the cable, go into the lounge, watch the TV, read for a while, and rest until you feel like you're sleepy again and want to go back to sleep. That does occasionally happen, but it's less frequent than you might well think. Our staff, I think, are very good at helping people to feel comfortable and create a homey environment. So it really is not very scary. It doesn't feel like a test, if you will. For routine clinical purposes, no medications are administered. Of course, if a patient is on an established regimen of medication that they take in the evening, then we would recommend that the patients bring in their medications and take them at the usual time.
Can all this be done in one night?
Usually it can be, particularly for patients that are being evaluated for a complaint of excessive sleepiness. Typically one night in the lab is all that's needed. I would say that for patients with chronic insomnia, one night is also very informative. Occasionally, though, we might recommend a second night in order to see if the patient is showing evidence of adaptation and can perhaps get a better night's sleep than they did on the first. Practice in that area is evolving, and typically, though, one night is going to yield the information that you need.
Now let me just see if I have it straight here to review the indications and the kind of diagnoses you might make with this assessment.
Okay.
You mentioned sleep apnea, periodic limb movements, irregular heartbeat,
yes,
depression, And explanations for being sleepy in the daytime, such as what?
The major issues to consider for daytime sleepiness would include conditions such as narcolepsy, cataplexy, sleep apnea syndrome, inadequate habitual sleep, which is probably by far the most important cause of daytime sleepiness, or the use of medications that could contribute to daytime sleepiness.
What's narcolepsy?
Narcolepsy is a disorder of excessive sleepiness that's characterized by irresistible daytime sleep attacks. The typical complaint of a patient with narcolepsy is that they have sudden, irresistible sleep attacks in a variety of situations, for example, while driving a car, while attending classes, during social occasions, or over a meal. Most of those patients also have episodes of cataplexy, which is loss of control over one's muscles, typically stimulated by strong emotion. For example, I had a surgeon who was a patient whose knees would buckle, who would have trouble maintaining an upright posture whenever a patient would say thank you and offer him praise for his good surgery. Or another patient who, whenever he tried to go fishing and would get a nibble, would get so excited that he would lose control over the muscles in his arms and drop his fishing rod. It can happen in any number of circumstances like that.
Sleep apnea, what's that and what do you do about it?
Sleep apnea involves a collapse of the upper airway during sleep, generating a partial or complete obstruction of the upper airway during sleep. Sleep apnea is heralded clinically in the patient who has excessive daytime sleepiness, but who also snores very loudly at night. Typically, the sleep apneic patient is a middle-aged male who is overweight and hypertensive. I would add quickly, though, that sleep apnea can and does occur in women as well as in men, but not as frequently in women as it does in men. These patients also need sleep laboratory evaluation, not only to document the severity of sleep-disordered breathing, but also to look for any coexisting cardiac problems or cardiac arrhythmias that often accompany sleep apnea. Part of the evaluation of the patient with sleep apnea also entails checking the patient's general medical health, including their blood pressure and their thyroid status. Some patients with sleep apnea do have underactive thyroid glands. Fortunately, it's a very treatable illness. Sometimes the treatment can involve weight loss, as well. A treatment of thyroid conditions may be helpful. Very often the treatment involves the use of a technique called CPAP, CPAP, which stands for continuous positive airway pressure. This helps to create what's called a pneumatic splint. It forces air into the patient's chest while they're asleep to maintain an open or patent airway.
And this does bring us into the question of using medications for insomnia. The benzodiazepines in particular, including the ones that are used as a hypnotic to get you to sleep, have some side effects. And these side effects can range from drowsiness the next day all the way to the development of a dependency on them.
That's right. For that reason, most sleep experts, and as well as the FDA, recommend the use of sedative hypnotic medications on a short-term basis over a period of several weeks for the treatment of acute or short-term insomnia. The use of these medications on a chronic basis is really not terribly well supported by scientific data, although it occurs all the time in clinical practice.
I would think at the patient's expense in a way, because if they're given for ordinary chronic insomnia without some very specific indication, perhaps periodic limb movement, if it has to be used for that, that it's going to chronically impair the patient's functioning.
I agree with you that the chronic use of a benzodiazepine could well result in an impairment of the patient's function unless there were a good specific indication for it, like periodic limb movements or perhaps an anxiety disorder where one might be using that kind of treatment. in my own practice, I'm much more likely to use, under those circumstances of chronic insomnia, low doses of a sedating antidepressant with due cognizance to the risk-benefits of such medications, and also in the context of good behavioral management of an insomnia complaint.
Now, there's a new drug out, zolpidem tartrate.
Right. Very useful agent, I think. Zolpidem is sold under the trade name of Ambien, and it's a fast-acting, short-acting sedative hypnotic, in many ways like Halcyon or triazolam in the rapidity of its onset and duration of action. The manufacturers of Zolpidem, Ambien, the Searle Corporation, also have argued that Zolpidem is very useful because it lacks the effect of rebound insomnia when it's discontinued, and in recommended doses typically is not associated with memory-disturbing effects. I found it to be a useful agent in my practice, and I use it also in my geriatric patients at a dose of 5 milligrams. In adult patients, the appropriate dose is probably 5 to 10 milligrams.
Do you feel it's as effective and perhaps safer than the benzodiazepines?
I feel it's as effective. It may be. It certainly is safe. It lacks muscle relaxing or myorelaxant effects in the doses recommended for sleep induction. That's made me wonder whether it might not be a tad safer in patients who have a tendency to sleep apnea than benzodiazepines. In other words, because of the absence of muscle relaxant effects, it might be less likely to cause or bring out latent sleep apnea in patients otherwise disposed to that. But that's a conjecture on my part, and I don't know of any data that actually address that issue. It's very important how work schedules affect sleep habits. This was one of the important focuses of the report of the National Sleep Commission several years ago, which has reported in JAMA that sleep deprivation is really a major public health problem in the United States and a major factor in many motor vehicle accidents and industrial accidents, as well as a factor in decreased quality of life. Americans tend to shortchange themselves, chronically getting less sleep than we really need, and partly that is related to lifestyle factors and to the fact that many people, for example, now need to hold down 2 jobs in order to make ends meet. In our culture, Dr. Flach, I think we tend to devalue sleep. I think that it's a waste of time. We don't really understand the functions of sleep well, and I think we pay the price for that.
You've been listening to Talk to the Doctor About Insomnia, featuring Dr. Frederic Flach and Dr. Charles Reynolds. In addition to this title, the Talk to the Doctor About series includes tapes on ulcers, headaches, diabetes, allergies, and back pain, and other important medical issues. This has been a Durkin Hayes Publishing and Hatherley Company production.
This is Dr. Frederic Flach to tell you about a very special offer. If you'd like to receive, free of charge, a special report on insomnia and its management, as well as a complimentary copy of the Talk to the Doctor Health Newsletter, just call 1-800-906-1234, and our publisher will gladly send these on to you. That's 1-800-906-1234.